We'll go ahead and get started. Very glad to welcome Dr. Keith Scott back to our faculty after a hiatus of what, a couple of years?
Couple of years.
He's going to talk to us today about something that we don't think about much, but the biology of injury is becoming a very important topic. And so, Keith?
One seems awful loud, doesn't it?
I can turn it down. I'll turn it down while you're talking.
Okay. All right, how's that? A little better? All right, that's a little better. The reason why I chose to talk about acute renal failure is because it's seen more often in critical care than what we would like, and it's often seen as an annoyance or just a secondary occurrence. And what we're really trying to promote as intensivists is that it actually has profound effects on outcome. It has profound effects on basically almost everything that we do now. As we start to understand that a lot of the renal failure that we see actually may be induced by us. And that we are probably doing things that aren't really wise, but we're not doing it on purpose, we're not being mean, we just really don't understand a lot of the biology. So this was supposed to be on my iPad, which I have all these great little, nice little animations, but I do want to tell you, the picture up there is Glacier Park. In my previous life, I was actually medical director of Glacier Park for a couple of years, and was director of their search and rescue, and did it when I was in Montana, and I was head of the critical care transport for our hospital, and part of that was from Glacier Park. So some of these pictures that you'll see are either pictures I took or other people that I know or rangers that I took. So I just thought I'd throw those in there just for a little bit of interest. But first of all, why should we care about acute kidney injury? And as I said, it has profound effects on outcome. It has profound effects on actually day-to-day care that we underappreciate. Again, we just say, well, yeah, the creatinine rose, but do we really understand what it means? And it's more than an annoyance. And what about creatinine in urine output? And we know that creatinine is a poor biomarker at best. Urine output's probably a little better biomarker. But all in all, these are pretty poor biomarkers of renal function in critical care. And then we're going to talk a little bit about biomarkers and what they really mean. When we look at acute kidney injury, what most people don't understand, and it actually took me a while to understand, is when the insult happens, there's this kind of common pathway. And this common pathway is that there starts to be epithelial differentiation. There appears to be undifferentiation, actually at a later stage, and that the repair machinery seems to be in place regardless of the insult. And at some point, and we don't know where this point is, it seems to repair to recovery or repair to long-term injury. And we don't really understand where this division comes from. But we know that if you look at the proteomics, if you look at the metabolomics of the kidney itself, regardless of the injury, there's a common pathway for days. And so what I'm hoping to stress is that in those days after injury, maybe the greatest thing that we can do to try to prevent renal injury is to try to manipulate that. Because the other option is it goes to a progressive fibrotic remodeling stage, and that leads to chronic kidney disease. And so again, there's this differentiation that seems to occur that we have to understand physiologically and then place it in a clinical context. If you look at this is mortality from acute kidney injury. 1968, there was a dramatic drop. Dialysis. Late 60s, early 70s, we had dialysis. We could actually save some of these people. If you look at from about 1970 to 2014, which is what we have the most recent data for, there's been no change in the reduction of mortality from acute kidney injury. Now that's a little disingenuous because our patients are certainly sicker now. They're surviving what they usually wouldn't survive. But for the most part, we've had very little impact on saving these patients from acute kidney injury. And if you look at death within 90 days of discharge, if you look at all patients that are discharged from the hospital, about 13% die within 90 days. If you have acute kidney injury as your primary diagnosis, so you come with acute glomerulonephritis, acute renal failure from a primary source, it's about 35. But if you come in with sepsis or surgical trauma, and then you develop renal failure, your actual mortality gets up to 50%. So something really, really bad happens when your kidneys don't work. And this is why we need to address this, because this is not an annoyance. This does not mean I have to adjust my vancomycin dose. This is a profound, I think, biomarker and process of acute and serious mortality. And if you look at the no acute kidney injury to severe, it's directly related. In 90-day, again, goes up to 29, but you add them together, that's your 50%. But the more severe, the higher the hospital mortality. So again, not an annoyance, it's something really bad happens when your kidneys begin to fail. And if you look at length of stay, hospital costs, 30-day admission, or hospital mortality, if you're in the severe range, and I'll talk what severe means, you have a 10 to 11 times higher risk of death, just primarily based on renal function. So again, something really, really bad happens to you when your kidneys start to fail. And some of this may be us, some of it may be the kidney injury that we don't understand, this neuroendocrine issue that kidneys have, but it's not a filtration problem, right? We can get people euvolemic, but still, even if we do, their mortality goes up. So something seriously happens when your kidneys no longer work, and this is something that I think we have to address and have to recognize as intensivists and try to prevent. Well, we use cardiac surgery as a very good model for acute kidney injury in the ICU. And there's a couple of reasons for it. One is we usually know their creatinine before they come in. We kind of know their renal function. We have very good timing on when the injury occurred. We kind of know when they were induced, when the cross clamp occurred, when they got hypotensive. But if you're shot in Monroe, how long you're hypotensive for, we don't know what you're, so it's not a great model. But cardiac surgery is actually a pretty good model in the surgery population to study acute kidney injury because, again, we know timing pretty precisely. We know exactly kind of when it happens and the influences that go in. And if you look at that mortality, again, depending on your degree of impairment, goes from 3% to 54%. So if you go into complete renal failure after cardiac surgery, your mortality is 50% regardless. No matter what your valve did, no matter how your arteries did, just the fact that you went into kidney failure really significantly impacted your survival. And this is kind of how we look at acute kidney injury. This is the AKIN classification, and basically we're using creatinine and we're looking at urine output. And you can see 1, 2, and 3. We also have called the rifle class, which looks at risk, injury, and failure, loss, and end stage. If you were to look where the red line is, going from risk to failure, that alone, in and of itself, is an independent risk factor of 90-day mortality after cardiac surgery. It, in fact, triples your mortality. So again, something really, really bad happens when your kidneys fail, and something we need to understand and recognize. This kind of the same thing, it just goes over more and more of what I'm saying is every time we look at cardiac surgery, and any time there is renal failure, mortality goes up, and it doesn't go up a little bit, it goes up a lot. It's logarithmic. And so you see mortality from 1.5% to 5%, from 3 to 50%. All those go into the fact that your kidneys start to fail. Again, something really, really bad happens. And I hope to explain a little bit of what we think happens, but we're not really sure. Well, why do we care? Well, just in cardiac surgery alone, 30% of patients that get cardiac surgery develop some degree of renal insufficiency. So again, even someone that has a very good postoperative course, they get their triple vessel, they do well, about a third of those still go into some degree of renal failure. And again, this directly impacts mortality. So we have to really recognize this a little better. So what about trauma? Well, these are mountain sheep. They're actually very friendly. If you get up close to them, they actually will come up and nudge you and try to butt you, because that's what they do. But they're pretty nice. But if you just look at trauma, so we take it out of the cardiac realm and we move it into trauma, the mortality rate again goes up significantly. And if they're older, seem to be female, worse injury. But if you look at this, even mild acute kidney injury has a 2.5 times higher risk of death. So even mild. So again, something we have to pay more and more and more attention to, what happens with acute kidney injury. And this looked at about 1,000 patients. And again, if you look, acute kidney injury occurred in almost a third. So it's not like something that just occasionally happens. It's happening all the time. And how much attention are we paying to it, and how much attention are we giving the consequences of renal failure? And if you look at kind of how this broke down, if you got more blood products, if your creatinine was higher, if your temperature was lower on admission, your lactate was worse, more chances of going into renal failure. And again, the sicker you are, the more likely you are to go into renal failure. But again, in spite of all of those and looking at all those and separating all those out, the fact that you go into renal failure itself is still the biggest leading cause of mortality in that group. So if you survived your first gunshot wound, what happens to your kidneys is, we don't know, but something bad happens. Because what we talk about all the time is, we're genetically engineered to escape from the lion or to be caught by the lion. We have no machinery to get picked up by a helicopter right after being mauled by the lion, brought to a trauma center, given someone else's blood, someone else's fluid, a bunch of antibiotics. We just don't know how to handle that. And so a lot of this may be that we just don't have the genetic machinery to be shot or to be run over. We need to get killed or escape. We're probably better off. But the in-between is what really gets us in trouble. And again, if you look at trauma associated with TBI, and there's about 10% that get it, but if you look at those patients, if you get acute kidney injury with a TBI, your mortality is 42% versus 18%. Again, something really bad happens when your kidneys fail. Even if your brain's badly injured, you separate all that out, still the kidney failure is one of the leading causes of morbidity, mortality in this group. And so something we have to really kind of address. And again, it's complex, we don't know all. We know that mannitol seems to make it worse. It's probably an independent risk factor of kidney failure in and of itself, but what do we give every trauma patient that has a head injury? We give mannitol. That in and of itself is a risk factor for renal failure. It's been shown to be a risk factor for renal failure in cardiac surgery. Mannitol is probably one of the worst things we can do to somebody, but we do it all the time. And again, we do it all the time because that's what we do. But in reality, we need to start thinking about the kidneys as the problem, not the brain. Because we can save the brain, but if we can't save the kidneys, we're probably not saving the life. And that's why we have to rethink this, I think, quite dramatically. If you just look at surgical sepsis, it obviously complicates it. But if you look at any type, and this was a great article in Journal of Trauma and Critical Care, really looking that if you just define acute kidney injury as just one of the things that we look at and we try to goal direct it. So let's try to resuscitate the kidneys. In spite of what the body's doing, we're probably going to do something good. And it's something that we're working through right now, but it does work that we have to try to resuscitate these kidneys in any way possible. So like I said, we know renal failure is bad, right? You never want to be in renal failure, and we know it's bad. But again, what happens when that acute injury occurs, again, there seems to be this common pathway of an injury response that at some point is uniform, but at some point diverges. And it's not the acute injury, it may be something secondary, because it seems to be day after day, for a couple of days after an acute insult, that you can actually salvage the kidney. if you don't do something else wrong. The problem is we never know that the kidneys are injured because we're using urine output and creatinine, which are really lousy biomarkers of acute kidney injury. But it's all we got, we think. I'll show you why it's not true. If we look at acute kidney injury, how did you learn it in med school? There's pre-renal, there's renal, and post-renal. We'll skip post-renal because put in a Foley or something and that pretty much cures it. But prerenal, renal, oliguric, non-oliguric is not separate diseases. These are spectrums of disease. And pre-renal is still renal injury. It's just not as bad as renal injury, but it's still just as bad. And the funny thing is, when you look at the data, pre-renal injury has the same mortality impact on post-surgical patients as does renal failure. It's just their spectrum of the disease. So this is just a spectrum. And so stop thinking of it as separate diseases. We're just looking at severity of the disease itself and reversibility. Because what happens in the pre-renal is you're probably in that corrective machinery that's actually easy to correct. And when you get more and more renal and more ischemic problems or more fluid issues or more edema of the kidneys, the ability to repair becomes harder and harder. And therefore, pre-renal and renal are the same disease, just varying degrees. And so we need to stop thinking about it differently. And because what do you hear? Oh yeah, BUN's 40, their creatinine's 0.5. Yeah, they're pre-renal, just give them some fluid. Yeah, that's probably right. But it's a machine reparative mechanism that's probably already established its ability to repair itself. You're not doing anything. It's just doing it itself. So why look at biomarkers? Why is creatinine and urine output so bad? Well, biomarkers, we know now the NIH defines it as any substance or structure that can be measured in the body that predicts and influences outcome. And that's kind of the definition of biomarkers right now. It really doesn't apply to urine output or creatinine. If we were to look, and the way we do it now, if you look at the receiver operating curve, which is really how we judge test, right? Because a perfect test is 100% sensitive and 100% specific. An imperfect test is this kind of line right here, which is 0.5, which is 50-50. It's a coin flip. If we were to look at white blood cell count to predict onset of sepsis in the ICU, what do you think the receiver operating curve of that is? It's actually 0.58. It's a little better than a coin toss, but not a lot. It's not a very good test. If you were to add procalcitonin to that and add the two, actually your receiver operating curve comes onto your positive predictive value is 85%. So again, you're using what's biologic, and then you're using a biomarker to help augment your diagnostic capabilities. And that's really what we're trying to do with acute renal failure because, again, if we start looking at creatinine, it's a bad test. Why is it a bad test? If you look at onset of injury, were to occur at time 0, and the injury continues, it takes almost 20 hours before you're going to see significant rise in creatinine. And so this red block that I have here, I call a vulnerability window, because that's when you think as a practitioner everything's okay. Can I get a CAT scan here with dye? Sure. Creatinine's normal, urine output's okay, right? Can I give him vancomycin? Sure. Give him here. Actually, give him some Toradol too, because he's still in pain. And restart his ACE so we can really be here. We do it all the time. Cardiac ICU, we do it all the time. We give them Toradol, we restart their ACE, right? But we're assuming this is normal, but the curve is clearly not, and the injury is ongoing. And so, again, creatinine, it's just, has too much of a time delay to be a good test for what we need to do in the ICU. It's probably okay for outpatient, it's okay for long-term, but for what we need in the ICU, it's just a bad test. Here again, this was just in PLOS last year, or year before, if you look at the same thing, serum creatinine, these are patients that went on to develop acute kidney injury or those that didn't. There was this 24-hour window where actually their creatinine was the same. And again, we have this same vulnerability window where we assume everything is normal. And so what we do is we say, yeah, give them vancomycin. In fact, give them Q12 hours, right? And we'll see what the next level is. Well, at that point, then you get a creatinine that's 2.4, and you went, holy cow, I've overshot. Or let's go ahead and get a CAT scan. Yeah, we can give them dye, the creatinine is normal. Again, we don't know that because creatinine is just not a good test. This is an interesting study that was done looking at acute kidney injury, looking at midkine and ingall, which is one of the biomarkers I'm going to talk about. And this was, again, cardiac surgery, again, because the timing is so precise, it's a good model to study. The time the aortic clamp happened, we saw a spike in midkine. By the time the end of the case, we actually had it declining. But if you can see, the ingall started to rise. It was post-op day and a half before we started seeing a rise in creatinine. And again, the same thing, this red box, this vulnerability window where we assume everything is normal. And so we can just go ahead and do whatever we want because the kidneys are okay. When in fact, they were never okay. We saw it here and we'll really see it here, but creatinine is way out here. The funny thing about this, when you look at urine output data, doesn't change. No difference between the ones that developed acute kidney injury and the ones that didn't. So even urine output, which is one of the criteria for acute kidney injury, is not a very good test. And we know creatinine is a lousy test, but urine output is also not a very good test. So we have to start looking for other things. This is the ones that didn't develop acute kidney injury. Again, midkine didn't go up, ingall didn't go up, they never developed acute kidney injury. Again, we'd be over here before we could actually rule that out. But we could actually have known it at the end of the case, looking at biomarkers. And again, what happens? We get this huge ingall spike, but creatinine here is normal. What if we do another injury here? This is where we give vancomycin at Q8-hour doses. This is when we say, you know what, take them back to CAT scanner, yeah, you can give them dye, creatinine is normal. But in reality, they've been in trouble the whole time. And again, why is this so important? Because this translates to a 50% mortality. And again, are we helping the process here? Because is that machinery, again, going to correct to normal, or is it going to correct to a fibrotic stage? We don't know, but maybe we're doing it. Again, here's ingall. You can see at 6 hours after the cardiac surgery, we saw a huge spike. We did not see a rise in creatinine from 0.85 to 0.1 for 24 hours. Again, no ingall spike here. So we knew it actually at 6 hours. Actually, we kind of got a feel at 3 hours after the case, whether there was injury or not. And so we're trying to translate this into other disciplines like trauma, other than cardiac surgery. Again, same thing. Ingall really spiked at 2 hours, the ones that went on to kidney injury and the ones that didn't. And same thing, this was aortic valve replacement, huge spike at 3 hours. Creatinine did not rise until 18 hours. So again, a very big delay, but we have to start really looking at these biomarkers as early diagnostic criteria. Because again, here's post-aortic valve, serum creatinine, and this was 3 hours, a little better than a coin flip, but if you added ingall, 0.84. You could go up here, and if you looked at urinary ingall, this was 4 hours post-bypass, we saw the predictive value was 0.9%. Creatinine was a coin flip. Again, trying to use these as good markers of predictability. I don't know, you can't see this very well, but this was actually, I was on with one of the rangers. He actually stopped his truck, got his gun out. I took this picture, but you can see some hikers here. That's a grizzly bear who's walking up, and he was going to shoot the bear if it got any closer. Fortunately, it ran away. This was spring, so humans aren't very tasty in spring. They are in fall because they get hyperphagic and they're going to hibernate, so they really like people in the fall, but in the spring it's pretty safe. So anyway, what does all that mean? Well, the old paradigm has actually been this, right? We start seeing a rise in creatinine. Oh, well, let's give them some fluid, see if their urine output improves. Oh, you know what? We better stop the vanc and maybe get a level. Let's see what tomorrow's level is. Oh, wow, look here, maybe we got to start dialysis. Again, we think it's just far too late. And if we look at the paradigm with biomarkers, where this has actually moved way over, and we start intervening very early when biomarkers are elevated but creatinine may not be, can we make a difference? And this is unanswered. But it is something we have to start looking at because, again, we're translating renal failure is a profound mortality effector. And if we can start getting in a new paradigm of start looking at biomarkers and interacting early and interjecting early, maybe we can try to prevent creatinine from rising. Now, not creatinine rising is bad, it's just it's a bad biomarker, right? It's a biomarker of something bad's already happened, but it doesn't tell you when or how. So again, why is timing important? Because if injury occurs, there's this common pathway. And this common pathway, like I said, it's been described over and over again, both metabolomics, proteomics, all this. The kidney wants to heal itself. Just something happens where there either no further injury and there's repair, or there's additional injury and fibrotic pathway. And what I am arguing, if we don't know what the creatinine is, we do a lot of dumb stuff in this reparative mechanism time frame that I think we need to start thinking a little better about. Sorry, this is mismarked. That's actually the glomerulus. That's actually proximal tubules. But these are the number of biomarkers that are actually being studied right now, a lot of them. And a lot of it has to do with, again, this epithelial differentiation, dedifferentiation, reparative model, restorative model, can or cannot occur. And these biomarkers are very reflective of this cellular pathway that goes on here. And so they're very, very sensitive and actually very, very good. NGAL is one of the first ones that have actually been out. It's been studied a long time. It's not available in the US as of yet. But that's their website. And if you look at, here's 31 trauma patients that were studied. NGAL levels of admission were significantly higher than those that developed AKI. And it seemed to persist for 2 days. So even this admission NGAL, we started seeing there was kidney injury from the initial insult. And so we knew it, and we did not have to wait for creatinine in this study. So we knew there was some potential injury. So how is this important? Why is this important? Because then, and maybe we don't do something stupid like, yeah, let's get a CAT scan and give as much dye as you possibly can so we can really see, or let's not give the Toradol, let's not restart the ACE inhibitor, let's not do some of the things that we normally do. Again, same thing, just reiterating that AKI, there's impaired absorption and there's increased excretion of NGAL, but almost any of the biomarkers have kind of the same pathway. Again, this is just the cutoff. We know that about 300 micrograms is a good cutoff for renal failure. And again, we see it within 2 hours after the insult. So very, very early, and again, long before creatinine. There are 2 PEDS trials ongoing right now. One is Taking Focus, which is a general critical care trial. The other is a post cardiac surgery pediatric trial. But again, they're looking at biomarkers to say, can we affect outcome and can we affect this poor mortality? And what they found, and particularly this Taking Focus trials, not only are we going to look on NGAL, we're also going to look at percent fluid overload. This brings into the second part of the study is the percent volume overload may be that insult that we are doing the most, that we think is the least harmful. That maybe it's not the dye, maybe it's not the vancomycin, it's not the Toradol, but perhaps it's the percent of volume overload. We're giving these patients way too much volume. Why is that important? If you look here, this is a great study. if you look at, if you're 20% volume overload, fluid overload, this is calculated by adult, your mortality is 65% opposed to 30%. That alone, just being a little volume overload, is maybe one of the biggest factors that we do, and we do it all the time. How many patients do we see that are 3, 4, 5, 6, 7, 8, 10, 12, 50 liters positive all the time? So maybe one of the biggest things that we're seeing and the biggest things that we're doing badly is not that they get renal failure, because we can't help the insult, right? We can't help some guy got shot, but we can help the secondary injury, and maybe volume overload is one of the biggest injuries that we allow to happen. If you look at the receiver operating curve, so if you look at just getting percent volume overload, predictive mortality is almost 80%. And it actually is exponential. So the greater your volume overload, the higher your mortality. So again, we do some really bad things. And if you look at this study, all of these, whether it's incidence of ARDS, multi-organ failure, recurrence of this, complications, we can look at surgical sepsis, wound infections, all go up with linearly with the degree of volume overload. So again, we have renal failure. We don't know we have renal failure. Then we give a bunch of fluid, and then what happens? We can't get rid of it, or we try to get rid of it, and we don't. So what happens? We get this syndrome of volume overload that, again, is a direct linear prediction of worse outcome. KIM1 is another biomarker that we're looking at. It's kidney injury molecule number 1. It's just one of the many. This is kind of interesting. This is a picture, actually, Highway 2 runs south of Glacier Park. It runs between really Shelby and Kalispell. And this was actually a guy, he and his wife stopped to eat. She was making dinner in the back of their camper. He decides to walk up this kind of Glacier Hill, and he actually didn't realize he was just taking pictures and spotted these bears. This is not what you want to see, because the next picture is him being unloaded. Actually died from his wounds, but took a picture of his killer. And we actually found the camera. The Rangers found it later, and that's where actually this picture came from, was his camera that they had found on the ground later. So again, this was actually in September. So don't hike Glacier in September. But anyway, again, kidney injury, molecule number 1 or whatever, they're all indicative of some degree and very specific for some degree of injury to the kidney apparatus. And again, these are the major ones that are being tested right now. There's, like I said, numerous others. But what's probably going to happen is we're probably going to start getting this injury panel. And we're probably going to have numerous biomarkers, whether it's Ingol, KIM1, IL-18, or this is a fatty acid protein. And basically this would be very specific for an acute ischemic injury. This would be specific for interstitial nephritis, and this would be much more specific for contrast-induced. And so what we may be getting is that not only can we find these molecules, we can always probably maybe even find out what caused it. And so we don't do the same thing over again, particularly something like this with interstitial nephritis. Well, we just stop the beta-lactam or whatever other thing that we think is causing it. But so we're probably going to start getting this injury panel thing. This is the one that's actually commercially available now. It's actually been available for about 6 months. It is a metallo-like protease 2, and this is insulin-like growth factor binding protein 7. And they actually, additive, have a very high predictive value of predicting acute kidney injury. And it takes 6 drops of plasma on this, and you get it in 20 minutes. If you look at the Ingol that's coming out, or we hope comes out, is actually based on the troponin platform. So you don't even need to buy new machinery. It's actually going to just plug right into what we do troponins with already. You just have to buy the disposables. So we're going to have these, and like I said, this is available absolutely right now. And it's something I think that we as an institution need to start start looking at and start using, because I think it's a game changer. And again, your risk score greater than 0.3, it means that you're very, very highly likely to develop acute kidney injury in 12 hours of testing. Now, it doesn't tell you the cause or otherwise, but it does tell you that watch your fluids. Let's not give them vancomycin. Actually, let's not do the CAT scan with dye. Let's do something different and think differently. The other question we have is, okay, if I have that and the NGAL is really high or the TIMP is really high and a little volume overload, will dialysis help? We don't know that. And that's something we're trying to answer right now. And the other is, are diuretics good or bad? Meaning, if they're volume overload, should I give them diuretics? Because we know now that just, we've always thought, well, if they're not making urine, let's give them a bunch of Lasix, they'll make urine, and that translates into improved renal function. It never has, it actually doesn't. In fact, if you look at the data from Mata et al., it actually reduced renal recovery. So the fact that you're giving Lasix actually probably doesn't help, except that it may help if there's pulmonary edema or volume overload. And so the only reason to give Lasix is not trying to recover the kidney, you're not trying to make the urine, you're just trying to get them out of volume overload. Because again, what I'm trying to sell today is that renal failure we don't know is happening, and then we do the second worst thing is volume overload them. And we need to be much more careful about how we give volume and how we take that off. And yes, diuretics probably don't help your kidneys. In fact, actually, there's more data says it probably harms them. But if it can keep you out of volume overload and help pulmonary edema, it's probably still a good thing. So do I use it? Yeah, but I don't use it because I'm trying to make urine. I'm using it because I'm trying to get them out of volume overload. So in summary, biomarkers, I think, are the future of kidney injury, but don't expect a pregnancy test. You're not going to get a positive or negative. You're going to get something in between. You're going to get a number that's going to be kind of weird. But if you apply it to the patient that you're with, just like we do with troponin or BNP or some of the other biomarkers, it can be extraordinarily diagnostic and helpful, and hopefully it's going to keep us out of trouble, stop us doing the next dumb thing, like not getting a CAT scan, not giving vancomycin at high dose, not redoing this, and not letting get volume overload long before creatinine rises. Yes, sir.
I really enjoyed the talk. I had a quick question. Is it the wrong thought process that the classic scenario when the patient is hypertensive, trauma patient, resuscitate crystalloids, you start blood products early, go for a CAT scan, gets contrast and comes in the ICU with classic AKI picture, and you try to make them euvolemic, and then you give them Lasix to convert AKI from molecular to non-molecular. Is that still the norm, or we should try to avoid that?
You should try to avoid that. I think the data is pretty clear that you're better probably to ultrafiltrate them off than you are to try to diurese them off. If they've had acute kidney injury, you know they have acute kidney injury, whether it's biomarker or creatinine, then to try to force them. Now, if you're just trying to get them out pulmonary edema so that you can ventilate them, of course use diuretics. But if you have the luxury of time, you're probably much better off from a kidney perspective to ultrafiltrate them off. And I'm a huge believer in ultrafiltration. We have several methods to do that right now. We've got aquaphoresis machines that'll do nothing but pure water. They hook to a triple lumen catheter, very easy to use. We need to be doing that more and more than just, because what we all try to do is make the balance sheet look good, right? But we don't always know that that's helping them. And I would rather ultrafiltrate them to euvolemia than diurese them to euvolemia if they're not in trouble. I think it's better on the kidney, and it seems to be, at least the data is clear, that recovery is better.
So that's a consult for you guys or for nephrology?
Oh, us, of course.
Nephrology. minutes?
This is all great. I guess my question is, I mean, in the past, our resuscitation has been with crystalloids. We're getting away from that now. So my assumption is we wouldn't have the interstitial issues because we're still stuck. We still got to do CAT scans.
Yeah, absolutely. You can't not do it. It's defining the second.
We can stop
hit.
giving vancomycin. We can
Right.
stop doing all that other
Yeah.
stuff, but we still got to do CAT scans.
I think my take home is that if I know they have kidney injury, and yes, I have to do a CAT scan because I got to see if they're bleeding, and I have to find that out. But I don't do the next dumb thing. Okay, I had injury from the injury itself. I probably secondarily doubled up with the CAT scan, but now I'm not going to do the next bad thing.
Now, with this, are we better off resuscitating very early on with blood and blood products, or are we still better off with the crystalloid?
A very wise intensivist I know that's sitting behind you told me once that, you replace what they lost. And the only way to make them better is replace what they lost. If you're trying to replace blood with crystalloid, you're going to be in a deficit at some point. Moderate amounts okay, and as long as they're diuresing off, that's okay. But when we start getting, and what we see all the time is the 15, 20, 30 liters positive, that's when multi-organ failure ensues and mortality really goes up dramatically. And that peds from 20% to 60%, just with an increase in 10% of volume overload. That's not a lot of fluid. It's a huge, profound impact on mortality. So we have to be careful. And, and actually what ATLS has been doing this for 10 years is euvolemic resuscitation, is try to get them to euvolemia. Yeah, you got to get it. And if they're losing, you get more, but it's still euvolemic resuscitation.
Yeah, well, ATLS is still written for the guy out in the boondocks
Right.
who doesn't have access to a blood bank, doesn't have
Right.
access to plasma or any of those things. Here, if somebody comes in straight, should we be giving blood right away? I mean, we're still giving like a liter, 2 liters.
I don't think anything good comes out of a crystalloid that I know of. I don't know of anything, unless you ran a marathon and that's all you've lost, I think it's great. But if you have not run a marathon and have not lost that, if you lost blood, you need blood. I don't think crystalloid is a substitute for that in any way, shape, or form.
Keith, that was excellent. There's a problem, a struggle, of course. Sometimes you guys deal with babies and children. I saw a lot of pediatric residents at the back. And that's a frustration for many of us. There are excellent studies.
Mm-hmm.
If I talk only about the perinatal period, that have shown, of course we always say that babies are not small adults or children, so one has to be very careful because the physiology is so different. However, people have done studies in Colombia and elsewhere that if you look at colloids, crystalloids, or blood, if a mother had complete abruption, the best damn thing is blood. So you get O negative blood,
Right.
or you take the, if you can get it from the placenta, use placenta blood. In the old days, we used to do that. So that's number one. Number two is you started your talk with the endothelial damage and the adhesion molecules that's starting this process, inflammatory process of cytokines, etc., which has been very well documented in multiple organ failures. So people are forgetting that. One of the things I often see when I walk from the PICU, the people are literally pushing in albumin, which we would never do that, because that's the worst damn thing you can do, because you got, for the reason I alluded to, transcapillary loss of that albumin. That's again, people have used that in animal models and shown that you're using I-125 albumin tag, that's leaking out within an hour or two at the most. So you're doing more harm than good. So anyway, having said that, the next real question is, has anybody correlated renal blood flow using Dopplers with
Yes.
these markers?
Very good, very, very well done. Actually, there was a study actually just published a couple of months ago that looked at renal blood flow in resuscitation, and they do not correlate. So the more fluid you give, this never
worse your
correlates
fluid will be, okay, right.
to improve renal flow. It never has, and it won't. And so this fact that we can resuscitate someone to better renal
Right.
dynamics
Oxymoron.
does not exist. The other thing about albumin, and remember the one thing about albumin is the glycocalyx is still the most important thing for oncotic pressure, and albumin may actually restore that. Even though it leaks, it actually may restore that glycocalyx that is, I think, extraordinarily beneficial. So I give albumin. I'm an albumin giver, I will. And I do it because I think that glycocalyx biology is what we need to concentrate on much more than leakage or passive oncotic flows, because they don't really matter. It's that glycocalyx that actually matters.
Has anybody looked into that and measured it?
Yeah,
Because
yeah.
in babies, it's the other way around. It doesn't,
Yeah.
you know, as I said, blood is the thing.
I don't know in neonates. I know it has been in pediatrics, and it has been very well studied in adults.
Okay, thank you.
Thank you all very much.